I'm back now for the lecture regarding local anesthetics. Again, my name is Paulo Rodrigues. I'm a consultant anesthesiologist here in Lisbon, Portugal, and thank you very much for attending this course. So our topic is, as I said, local anesthetics. So I have no conflicts to declare regarding this subject, and our outline will be mainly talk about the chemical structure and mechanism of action of local anesthetics, which is being subject of really extensive investigation today, as we are going to see, and some details about the pharmacokinetics and pharmacodynamics, some details also about additives, adjuvants, and toxicity, new uses, and finally our references. So we are not going, because of lack of time, to detail important aspects regarding neurophysiology, because they've been already detailed in other lectures, namely regarding neurophysiology and the way the nerve impulse is conducted in the central nervous system and peripheral nervous system. And also, we won't have time to detail clinical applications. It will be addressed by Professor Altensheim in his lecture regarding regional anesthesia in the anesthetic practice, which will be next week. So, local anesthetics are drugs that block nerve conduction when applied locally to nerve tissue in appropriate concentrations. They act on any part of the nervous system and on every type of nerve fiber in contact with the nerve trunk. These drugs can cause both sensory and motor paralysis in the innervated area, and its action is, unless there is a problem, completely reversible. These drugs have been firstly synthesized by Niemann in Germany in 1860 from the leaves of coca, and he isolated and purified an alkaloid of coca and named it cocaine. And actually the first description of tongue anesthesia after chewing coca leaves comes also from that year by Scherzer. And you may see here that cocaine, introduced in clinical practice in 1884, and you can see that, for instance, lidocaine is as old as 1948 coming into clinical practice. And as you know, you may see the relevance that lidocaine is having today and really changing our anesthesia practice. The last local anesthetic introduced into clinical practice were ropivacaine and levobupivacaine, and they date already from the last century. So these are quite old drugs in our armamentary from anesthesia drugs. There are two main classes of local anesthetics used today, the ester type and the amide type. And the ester type characteristics are shorter duration of action, lower toxicity. Most of them are hydrolyzed by plasma cholinesterase, also articaine, and they have the potential for allergies due to para-aminobenzoic acid origin. Some of the examples are procaine and cocaine chloroprocaine. And the broader group of the amide type, which are most used in clinical practice, has intermediate or long duration of action, higher potential for toxicity, hepatic metabolism, and particularly one of it's prilocaine has the potential for methylglobinaemia if used in high dose, especially in infants. These are the ones that are mostly used in clinical practice, like lidocaine, bupivacaine, levobupivacaine, and also some that are used mainly in dental practice, such as articaine. Local anesthetics share a typical structure. There are molecules with three main groups: one, a lipophilic part, then an intermediate bond, a linkage between this lipophilic part, and an amine group, usually, which is the hydrophilic part. This bond, as seen before, can have a linkage, an ester linkage, or an amide linkage. And we can see that here, for instance, the amino acid chloroprocaine with the ester linkage, and bupivacaine with the amino amide linkage. There is also a third group, usually not mentioned, the phenylcarbamic group. And these are some drugs coming from that group, which are esters with a substitutional alkoxy of the phenylcarbamic acid and have very high local anesthetic potency. And despite its relatively safe toxicity profile, they have not been introduced in clinical practice, but they are being subject of important chemical research because its potency uniquely increases with decreasing pH of the external medium, which may be important in some clinical situations. So this structure has a particular relevance. So the size of the alkyl substituents, it's that bigger, it's more potent. So the substitution for the alkyl group, such as ropivacaine C3H6, is less potent than bupivacaine, and mepivacaine is even less potent than these two. So the bigger the substituents, the more potent the molecules are. Also, usually, local anesthetics are delivered in racemic misters, which means that there are two enantiomers in equal proportions in the presentation of the drug. These enantiomers have different pharmacodynamic properties, and actually they are stereoisomers, like having two hands in front of each other. So they have different pharmacodynamic properties, and it was the isolation of these two enantiomers, such as the levobupivacaine or S-ropivacaine and the levobupivacaine, that produced these late two anesthetics being introduced in the market. They have the particular importance of having lower toxicity compared to the racemic mister of the local anesthetics. So as the opioids, local anesthetics are also weak bases, so they do not dissociate completely in water, and they accept proton from the water molecules. So they exist in the ionized form or in the basic form. And the amount of these two different forms is dependent on the pKa, the ionization constant of the local anesthetic, which is the pH, where 50% of the local anesthetic is in solution, is equal to the concentration of the charged cation. This is very relevant because this is going to give us different clinical details. You can see here that the pKa of most of the local anesthetics is higher than the physiological pKa, and actually the closer the pKa to the physiological PA. So the higher proportion of local anesthetic molecules in the basic form will be able to penetrate neurons or cell membranes. So these will give the local anesthetic a faster onset of action. And the higher lipophilicity will give the local anesthetic the characteristic of having higher potency and also duration of action. With increased concentrations of the local anesthetics, also the peak of the action potential is reduced, so the fine threshold increases and impulse conduction is attenuated. The refractory period will be lengthened and increased concentrations will inhibit as the whole nerve conducting to a full block of the nerve transmission. So what happens is that it is the basic form that may penetrate the epineurium and also the phospholipid membrane, and inside the cell the local anesthetic will in the base form will dissociate again to its ionized form, and it is this ionized form that will block sodium channels and producing the blockade of the nerve impulse conduction. And this is the form of the sodium channel, and its conformation of its subunits will be changed by the presence of the local anesthetics inside the cell. So this sodium channel has 9 identified subtypes, and these can be classified according to the sensibility of the venom from this pufferfish, which is tetrodotoxin, this fish and all other species, namely marine species. And these subtypes of the sodium channel may be associated with some specific diseases called channelopathies, and this is also being subject of extensive investigation today in order to try to develop selective drugs in order to block these specific subtypes of the sodium channel. So regarding the pharmacokinetics and the basic characteristics of absorption, distribution, metabolism, and excretion in pharmacokinetics, these will be determined by the amount of local anesthetic that is injected into the tissue or the patient, the rate of absorption from the site of injection, the tissue distribution, biotransformation, and excretion, which will be influenced by age, cardiovascular status, and hepatic function. So absorption will be influenced regarding the site of injections by the type of tissue. So highly vascular tissues will absorb faster the local anesthetic, producing higher peak plasma levels. And this will be highest after, for instance, an intercostal nerve block, and then in decrescent manner, caudal, epidural, lumbar, epidural brachioplexus plexus, or subcutaneous tissue. So the total amount injected must be adapted to the site, and we have to be aware of the resorption phase in some areas. Sometimes there is a slower second peak of local anesthetic coming from the lipid compartment. Regarding the dose, there is a linear relation between the amount of local anesthetic injected and the peak plasma level. So the higher the dose, the higher peak plasma levels. Lipophilic drugs will have a slower absorption because they will be more grabbed by the cells. And addition of vasoactive agents like adrenaline will limit the rate of systemic absorption, but of course there is the potential either for local ischemia or systemic toxicity from the usage of the vasoconstrictor. Regarding distribution, it can be described in a two-compartment model with a rapid disappearance phase by uptake from the highly perfused organs, and then a slower phase, which is a function of the particular drug, its lipophilicity and the protein binding. The pattern of distribution will be largely dependent on the organ perfusion. For instance, the heart and the brain will have much higher concentrations of the local anesthetic initially, and this will be one of the most important factors concerning toxicity. Also, the plasma protein binding is very relevant, and for instance, we have to be very cautious on pregnant patients due to the fact that they are more diluted and also being more prone to toxicity. Metabolism and elimination is different concerning the two classes. The esters will be hydrolyzed in plasma by the pseudocholinesterase enzymes, and aminoamides will have the degradation enzymatically, primarily in the liver, also in the lung, and its metabolites will be excreted by the kidney. So half-life of these drugs will be increased in older people, in neonates and younger infants, which are immature hepatic enzyme systems, those who have liver disease, or in pregnancy due to the protein binding changes and also decreased clearance. So local anesthetics also have difference based on the speed of onset, duration of effect, potency, the minimal local anesthetic concentrations required for being efficacious in 50% of the patients, its metabolism and elimination, and the toxicity. So again, the speed of onset will be dependent on the physicochemical properties and the concentration. The duration will be influenced by protein binding and lipophilicity, and by the addition by the vasodilator and vasoconstrictor properties of the drug. For instance, ropivacaine has some vasoconstrictor properties. Potency will be influenced by lipid solubility, and the lipophilic local anesthetic will be more potent, and highly lipid soluble drugs will be trapped in adipose tissue, so being available locally for producing its effects. And also levobupivacaine, the enantiomer, is less potent than racemic bupivacaine, as we said before. Regarding additives, which are adjuncts to increase local anesthetic activity, adding opioids to local anesthetics have a synergistic action in axial anesthesia, as we know, and adding dexamethasone either by IV injection or mixing in perineural with the local anesthetic may prolong blocks in a relevant way. It's classical the usage of epinephrine to decrease the rate of vascular absorption, so limiting the potential for toxicity from the local anesthetic, and also as a marker of inadvertent IV injection, but be aware of false negatives. And also the usage of alpha-2 agonists like dexmedetomidine may prolong motor and sensor block and prolong local anesthetics effects for up to 4 hours with some risk of side effects. Finally, carbonation or alkalinization of the local anesthetic may accelerate the onset and decrease the MLAC, but in my clinical experience, it's not very useful, not practical to perform. And be aware also that sometimes your failure in a particular technique will not always be due to bad technique, but mainly to these pharmacokinetic and pharmacodynamic aspects. So there may be inflammation at the site of the injection, which increases local blood flow, produces acidosis, so it will diminish the amount of local anesthetic available to penetrate tissues and cells. And due to the local edema and the sensitization of nerves and central sensitization, so it may diminish the effect of local anesthetic. Also, there may be tolerance developed during time, and also there is effect indeed. Some patients claim that, and it's true, that some patients may have some resistance to local anesthetics. So there are some persons that do show selective resistance to specific local anesthetics, or even those, for instance, that have been exposed to some venoms can have local anesthetic resistance. So before going to the new local usage of local anesthetics and some details about local anesthetic systemic toxicity, this is a quite frequent question in the during our exams, and so the clinical symptoms are here displayed on the left. And actually, the risk for this toxicity is increased by age, by the dose of the local anesthetic used, by the type of lock. Those which are performed nearby big vascular trunks are more risky, and without the usage of echo and or neurosimulator. In patients that have hypoproteinemia, true or relative pregnancy, those who have acidosis or hypercarbia. And we do know that sometimes when local anesthetics are alkalinized, in order may have more potent probability of causing toxicity. So treatment is to stop administration. Those who have CNS symptoms should be counteracted by benzodiazepines. There are some CPR differences which you should mention during your exam. And also, usually you are asked about the usage of lipid infusions, intralipid or similar, and you'll be asked about the doses usually utilized. So regarding the new usages for local anesthetics, so we are seeing now extensive investigations regarding this, either for the continuous intravenous perioperative infusion of lidocaine in order to try to diminish post-operative pain and increase or provide better recovery in adults, mainly regarding the post-operative nausea and vomiting aspects, and also ileus paralysis, time to first flatus or defecation, and also regarding pain. Also, it's being also used in order to relieve neuropathic pain in intravenous administrations. And nowadays, it's thought also that the perioperative intravenous lidocaine may have potential mechanisms of anti-neoplastic effects. And so direct effects on cancer cells, also in immune cells, on angiogenesis by inhibition of several pathways, and also on inflammation. And actually, some recent papers suggest that an intravenous infusion of lidocaine administered perioperatively may act as a simple, inexpensive, and effective chemotherapeutic agent in addition to its potential analgesic properties. So it's being really the subject of many clinical investigations. There are papers recently published that do not suggest any benefit in certain types of cancers like pancreatic cancer. But on the contrary, there are others that do suggest that these effects are relevant. Also, regarding pain treatment, there is already a consensus statement regarding the intravenous usage of lidocaine, and be aware that after it has to be approved by local or national committee and have the consent of patient, and should not be used in conjunction with other local anesthetics, and loading doses are subject of different protocols, but usually goes to between 1 and 2 milligrams per kilo, and then an infusion. Patients should be in high dependence units afterwards and be aware of the risk of toxicity. There are also new formulations for the administration of local anesthetics, like the liposomal encapsulation of bupivacaine. But there are some papers suggesting that it may not be very beneficial, but there are also other papers suggesting that indeed there are benefits from this utilization. And there are being developed specific subtypes of channel blockers, which are like neosaxitonin, that may prolong the blockade up to 5 times and lower the toxicity regarding the cardiac cells, and monoclonal antibodies regarding hyperalgesia and pain insensitivity in patients with channelopathies. Also being used and suggested that its effect is relevant as antimicrobial agents, such as in the nose, even in the eye, and at the prophylaxis of surgical wound infections, the diminution of the incidence of catheter-related association infections, and the changes in the oral biofilm in mucosa and inhibition of respiratory pathogens, and also diminishing bacteria in epidural catheter-related infection. So there are many research going on these potential usages of local anesthetics. So we're finishing. This is the main bibliography for this lecture. If you email me, I may provide you with a link for a folder with some papers regarding what we've been speaking. And thank you very much for your attention. And I hope you will enjoy the rest of this basic and clinical science and CZ course. Thank you. So a question about local anesthetics that you may be asked is, could you please describe the different advantages of some of the new uses of local anesthetics like lidocaine perioperative infusions?